event today. So just to give you a quick reminder on housekeeping, if you could please keep your mics off during the presentations. We want this to be an interactive session, so please use the chat box and introduce yourselves, share thoughts, comments and questions throughout the morning. Also, we will be recording the event today, and the link together with the slides will be available after the event. So, sorry, Isha, just to let you know, my slides aren't moving. I don't know whether they are forever. There, thank you. So just to introduce the collaborative group. So it is made up of 5 partners from across the Northwest, representing the NHS, social care and local government. So that is MIA, Advancing Quality Alliance, the Northwest Leadership Academy, Northwest Employers and the Northwest Association of Directors and Adult Social Care. So today's session is focused on unlocking sustainable productivity and building resilient health and social care systems. So over the next couple of hours, we want to explore the challenge of improving productivity within the NHS and wider sector and examine how a shift in mindset and narrative may support, understand why productivity should be viewed as a lever for improving care quality and sustainability and not just for meeting financial targets, to diagnose any barriers and enablers, identifying systemic challenges such as underinvestment, poor patient flow, etc., and to champion cultural change and to demonstrate how leader and governance can foster a culture of continuous improvement and trust. So the agenda is up on screen. So just to say, so I'm obviously just doing the welcome and introductions. We've then got our first of our speakers at 20 to 10, our second speaker at 10 o'clock. If there are any questions in the chat, we will pause for 10 minutes or so just to take any comments, queries, questions, etc. And then we'll go on to our third speaker. And then 10 to 11, we'll bring together all of reflections and any questions that anyone will have, and then we'll aim to finish at 11:30. So just to welcome today's speakers, I'll just do a very brief overview, and then as the speakers come on, they will introduce themselves and give a little bit about their background. So we've got 3 speakers today. We've got Stephen Rocks. Stephen is the Head of Secretariat for the NHS Productivity Commission. He's also an economist in the Health Foundation. We've got Bart van Ark, who is a Professor of Productivity at Alliance Manchester Business School and also Principal Investigator of the Productivity Institute, and James Davis, Head of Digital Productivity from the Transformation Partnership in Health and Care. So on that note, I will hand you over to our first speaker, which is Stephen Rocks.
Morning, everyone. Thanks so much for having me here today. So as introduced there, I'm Stephen Rocks. I'm an economist by background. I work at the Health Foundation. Normally I've worked on issues of funding and finance, but at the moment I'm working on an NHS Productivity Commission, and I'm going to speak to some of that today. I'm just going to bring up my slides if I can, just so I can control them. Can everyone see my slide deck?
Yeah, we can see them, Stephen.
Great stuff. So I just thought I'd kick off with a quick fact here, and this comes from the first report that we put out from the Productivity Commission. And basically what that tells us is that if productivity had continued to grow as we'd expected before the pandemic, the NHS would be around 14% more productive. And as I said there, that's equivalent to about £20 billion of additional care. And I should stress, we're not thinking about that as £20 billion that we can, take out, as it were. It's additional care, and it's the care that can go to patients. And all I really want to say with this is productivity really matters. And it really matters if productivity falls, and if it doesn't grow the way we want it to, it impacts patients. As I said, we started a productivity commission at the Health Foundation, partly because we've seen the slowdown in productivity since the pandemic, that fall that occurred, and I'll say more about that. But it's also looking forward at the challenges the system faces, and we know that productivity is really very vital to deliver sustainable, high-quality healthcare. I've just put a wee bit of information here about how the commission's set up. So we have 2 co-chairs, which is Anita Charlesworth at the Health Foundation, and someone called Tara Alice, who's an economist by background as well, and has a wider read across different sectors employers and the larger public sector. We have a number of commissioners across the Commission looking across 4 different areas, and I'll speak about those 4 areas in depth. You can see their names there. And we also have a broad expert advisory panel, and that draws from across the NHS, the HSC, think tanks, a range of other organisations. And partly that's because we want to bring a very wide perspective on productivity and to build consensus about why it matters. And lastly, there I've just listed the Secretariat team. I've put a couple of QR codes here if anyone wants to be able to see more information about the Commission, but you'll have all these slides shared, of course. So that's just by way of introduction. What I want to cover in my slides today, 4 things. So starting with where NHS productivity stands today. I then want to speak about why traditional measures of productivity are too narrow, which is one of the things that I think we want to convey from this entire session, and hopefully I can start to make that case, although I know Bart will also be touching on that afterwards. I'll then come on to what the Commission is finding and some of the emerging areas for recommendations. I should say I'm very pleased that we have space for discussion and there's a Q&A and so on. It's fantastic for us to hear from you at this point in time. We're working to develop a roadmap from the Commission for the end of September, but we still very much want to hear what people think about what we're saying. So whatever resonates with you, it'd be great to hear. If there's anything missing or anything that we're not saying, it's great to hear that from you. So I'll get started. So first, in terms of where productivity stands today. So what is productivity? I've already started speaking about it. I don't know for how many people how this is understood, as it were, but this typical metric, the typical way that productivity is measured, it compares 2 things. So one is the outputs from the healthcare system, and by that we mean all the different activities that the health system does. That could be anything from GP appointments, diagnostic tests, procedures, and in most measures these are weighted by costs. So something like a longer inpatient stay is ascribed a higher weight than a first outpatient attendance, for example. So you take all those things together and you get the NHS output. And you then compare that with inputs, and that's things like staff, goods and services, things like drugs or independent sector use, and then capital consumption. And effectively, when we're asking the question, is productivity increasing, we're asking, is output growing faster than inputs? If output's growing faster, that means productivity is rising. If inputs are growing faster than outputs, that means productivity is falling. So if I take that definition of productivity, if we look at how that's performed over time, this goes back to 1995 when the Office for National Statistics started measuring NHS productivity, or when this metric goes back to. And what you can see is productivity has increased over time. Sorry, I just heard someone come in there, but the average growth here is about 0.6% each year. That might not sound like a lot, but when that compounds over time, what you can see is the green line, if you look before the COVID-19 pandemic, is about 20% higher. That means that for every unit of input, if you like, every staff member, effectively you're getting 20% more out in terms of activity and services for patients. This growth hasn't been even over time. So what you can see is that during the 2000s, it doesn't rise quite as much. And that's a period when a lot of additional funding was going in. So inputs were growing faster and it took time for output to catch up. When productivity really started to accelerate is after the 2010s. And in particular, between about 2010 and 2015, when there was a huge emphasis, the Nicholson challenge on getting efficiencies out of the NHS, that's when you see this metric grow most significantly. And that point, it was growing at around 2% or slightly more each year. You can then see, I put that sharp line there for the COVID-19 pandemic. You see that sharp drop in productivity. And again, that's partly because inputs continue to grow. And especially at the outset of the pandemic, we also had, that halt to a lot of routine activities. So that explains that very, very sharp drop. But even as activities started to come back on, we haven't seen productivity fully recover. This official statistic only goes up to about 2022, but there is more data. So NHS England have also started developing their own measure, which is more up to date. And that shows that productivity has been growing about 2% in the acute sector since about 2002, 2023. What this chart also shows is that everywhere saw a drop in productivity. This is not only a question of the UK or England. Most advanced health systems saw a drop in productivity. As far as we have data that we can compare, we see this across lots of different places. But the drop in England was actually steeper and has taken longer to recover. It's proven more sort of enduring, if you like. So partly the question for us when we started looking at this is, why did it fall more in the UK? And what we can see comparing different countries is that in the UK, we actually added more staff to hospitals than other countries did. Now, there are a range of reasons for this, including things like safe staffing initiatives that led to this increase. But we also saw activity in hospitals, so this is proxied here by discharges, fall more than most other places. So if you take those two things together, adding a lot more inputs and then the fall in activity, that explains why we had that steeper fall in the UK. I think the key thing here is, again, we added those staff into hospitals disproportionately. So again, it's actually about a 20% increase now in staff in hospitals, and that's across a range of different roles. I think partly, as one of our co-chairs, Tara Alice, put it, one of the questions here, was that staff in hospitals the particular bottleneck resource for the health system? When we're thinking about productivity, part of what we're seeking to ask is, where can we unlock the most activity, if you like? What would we add to help do that? And again, if we look at the UK over time, if we look at England, what we have is quite high occupancy rates in hospital, a lot of pressure on beds, underinvestment in other sectors. But again, a lot of the resource went into hospital over the pandemic. So why does this all matter? We know, you know this, the NHS faces mounting pressures. The Health Foundation, we've done projections of the number of people with major illness, and it shows that's set to increase. So by 2040, 9.1 million people in England are projected to be living with major illness. And over and above that, we've got very tight funding. So partly due to the weaker, wider economy, that means there's less tax revenue being raised over time, where the growth in tax revenue is not as high. But we also have other spending pressures on public services. So things like defence spending, which is very topical at the moment, of course. That all adds up to say that the NHS may not see as high funding growth as it has historically. We can expect that to be tighter going forward. And without stronger productivity growth, the NHS is going to find it difficult to deliver outcomes within existing resources. But what we've typically been hearing from people is that just exhorting more effort from staff under the current model will not deliver the improvement that's needed. And partly to help answer this, we brought together a range of different experts from the health system. So that includes people on the front line, it includes people from sort of research organisations and from sort of policy groups. And the question we asked them is, what do you think will happen to NHS productivity going forward? And we looked at a sort of 5-year and 10-year horizon. So again, you can see that historic number on the left-hand side, that's 0.6% a year. The government target at the moment is 2% growth. And as I said, that has been realised in the acute sector for the last few years. But when we asked experts what we thought would happen going forward, they were more sanguine. They thought about 0.7% growth in what I've said there is the momentum scenario, so just looking at current policy mix. When we asked them about a highly tech-enabled scenario, where the NHS is able to adopt more technology more quickly, that rose to about 1.4%. So there are some grounds for optimism there. But generally speaking, again, just exhorting more effort under current policy, we don't think will deliver what's needed. But next I want to talk about, I've used this measure from the ONS, and I've spoken about the rates over time and so on. And I've tried to set this up in relation to that. But actually, when we did that session with stakeholders, they pushed back very strongly. And likewise, we've been running a call for evidence as part of the Commission, and we've also been speaking to a range of people across the system, and we get a lot of pushback about these measures don't actually capture what matters. So again, I said that traditional metric, it compares inputs and outputs, and that tells you about how activity is increasing. But actually the framing that most people tell us is important are the outcomes that patients get from the care that's delivered. It's that we should be thinking about. So from going all the way through from the funding that goes in to the outcomes that the health system achieves. And I think everyone can agree that ultimately is the outcomes that the NHS is set to is there for. Now I should say here, whilst I say that, I'm not throwing out the other thing. If you think about that as being that relationship between inputs and outputs, you might refer to that as efficiency. I'm not saying that efficiency doesn't matter. And actually one of the strongest conversations we had with stakeholders is when somebody made quite an impassioned plea and said that in fact efficiency is in itself a patient safety outcome, if you like, because if you can see one more patient as part of a session, then that is the patient receiving that care. It's just not the only thing that matters, and we need to look across the whole gambit. And part of the reason for that is if we step back and look back before the pandemic, what we can see is the UK was relatively efficient. So I mentioned quite high occupancy rates, low length of stay. These are traditional metrics of efficiency and things that we might look for to improve that productivity metric. The UK was already performing well on that. But if we compare funding to outcomes, so what I've termed effectiveness there, the UK was performing less well. So that opens up some questions also. So it's not just whether we're doing things right, as it were, it's are we doing the right things? And I said before, disproportionately over time, for example, we've invested in the acute sector and underinvested in things like primary care. So again, it raises that question of what economists call allocative efficiency. Are we spending money on the right things? And it's more than that. We really need to look beyond activity if we're going to maximize value. And partly what I've picked out here is some OECD research that shows that quite a lot of activity is actually to prevent, is to correct mistakes that have happened, or infections, for example, that people catch in hospitals. And again, tackling that feels just as important as doing more activity, if you like. And likewise, we have a radiologist on our expert advisory panel. And I think I was surprised even at the extent to which she would recognize that as a radiologist. But we saw a very large increase in diagnostic tests through the 2010s. But she was quite clear that that increase in the volume of tests, if that's low value, that doesn't necessarily improve things for individuals. So again, she was very against the idea that we can just continue to grow and grow and grow activity. We need to target that and think about who needs it most. And partly that's that switch from activity to thinking about value. Okay, so I've set this up in terms of how we've positioned the Commission, what we know about productivity already. What I want to sort of relay here is a bit about what we've been finding thus far on the Commission. And one of the first things I want to say is the problem isn't the funding model or a need for reorganization. So I think some people now will start to think, or you might hear this in sort of political circles, that in fact there's a taxation system that is the root of the problem. We do not see that. There's good research that shows that you get systems funded by taxation and systems funded by social insurance, and you get good and bad within that. So it's not that question of the wider structure that determines things. It is the policies and incentives that exist within that. Nor, I mean, we're very unlikely as a Commission to incline towards major structural reorganisation as being the answer. If anything, the pace and the repetition of restructuring is something that has hindered progress in the NHS. So we're unlikely to reach for that as a lever. So the barriers are more systemic. They're not these big structural factors. And in terms of how we approach this, I've already said that the Commissioner is working across these domains. We've identified 4 key drivers based on both what matters for productivity across the wider economy, but really then tailoring that to healthcare. And the 4 things that we've identified are the workforce, which are obviously at the heart of everything the health system does. It's capital, which is the spending on things like equipment and buildings. It's technology and innovation. And lastly, it's what we've called transformation. Albeit I know transformation has quite a particular resonance in healthcare, but really by there we mean the wider system leadership. And what I'm going to do is just say a bit about each of these drivers and some of the challenges and barriers that we've been hearing when looking at each of these in turn. So first off, when we look at the workforce, so low engagement undermines productivity. And we saw staff survey results come out last week that again showed that engagement is down from before the pandemic. And there are a number of worrying metrics there. And I think something that I'd really like to stress here is for us, you know, the staff engagement, staff satisfaction, that isn't a sort of frilly nice to have thing that sits on the side. It is at the heart of delivering improvements in healthcare, because ultimately, as some stakeholders tell us, it's staff that actually have to enact things and make change, and they have to want to do that for that to happen and to work. So really putting engagement at the heart of what productivity is vitally important. And I put a nice quote here from somebody that attended one of our recent evidence events, who really just stressed that a success measure for any strategy for improving productivity would be if you started to see staff feeling more empowered. If that shifted from being less empowered to more empowered, that would be a really good signal and sign that things were working. Again, across the NHS, management and HR capability is quite thin and reactive. So the NHS is undermanaged relative to a lot of different other sectors and services. Still very rigid roles, and again, there's very long-standing reasons for this. The NHS has a very long history in professional bodies and so on, but quite rigid roles and siloed training, and weak support for the type of sort of flexible, adaptive approach you might want to see going forward, especially as we start to bring on more technology and redesign pathways, if that's going to be a route to productivity. And then finally, something that surprised me to some extent is the NHS, and I'll say this again when we think about system leadership, in some respects, it's quite tightly constrained and quite tightly monitored. But there isn't as strong an understanding as you might expect of how staff time is being used or what drives well-being and workload. So again, limited understanding there. If we think about capital, I spoke about the fact that in the 2010s we saw high efficiency growth. But one of the problems with that, and again, I think in the setup here, we said we want to look at sustainable productivity. One of the issues with saying that is that in the 2010s, we also saw quite significant underinvestment in things like capital. So yes, we eked out productivity, within each year, but we've actually set up a wider problem, which is this chronic underinvestment in capital in the healthcare system. But interestingly, aside that, we actually have persistent underspends. Sometimes that might be because capital is being held back to support revenue, but we also see a very complex, fragmented capital system that actually makes it quite difficult to get money out. It also makes it difficult with lots of small pots of capital, for example. That makes it harder to do the things that estates leads might actually think is most important. What we tend to hear is that you might have a list of projects that you want to invest in, and right at the top is something you can't do because you can't stitch together the money, for example, and you're having to go down that list and find a project that fits the money rather than doing the thing that's most important. There's also been just a failure to modernise the estate, but also poor utilisation of the existing estate. Especially we hear that, for instance, in community services, our understanding of the estate that we have available in all the different sites is actually quite poor. And again, no coherent long-term capital strategy. I'll just bring attention then to that final statistic there that's in the box. In most sectors, when you think about productivity, you often think about investing more in capital so that each worker is supported by better technology and can do their job better. What we've actually seen in the NHS is increases in frontline staff, but them having less equipment and support to do their job. And so capital per worker has fallen by about 1/3 since 2010. Moving on to technology and innovation. Again, what we hear is that the NHS has very weak digital foundations. And again, all of you will know this very well. This shows up as poor connectivity or slow laptops, out of date software and technology. So again, those weak digital foundations, but also interoperability. Again, this has been such a focus for a long time, but hasn't been cracked. So the ability of data to move across different sites and settings for data on, for a very interesting example we had was about frailty, that the GP might understand a little bit frailty, but can the secondary care setting see that and understand that when a patient shows up at A&E, that these things hold back productivity. We also have what can be, I think, understood as quite a supply-led market, so not necessarily very responsive to service needs. And you can see this in terms of, lock-in to large EPR providers that don't then have a huge incentive to adapt and make it easier for the NHS to get the most out of EPRs. And that's also then found in insufficient sort of implementation and pathway redesign. And it says it down at the bottom there. But again, we do have investment in technology. We do now have EPRs across almost every provider setting, but we actually don't tend to see the gains coming forward from that. And that's the challenge. The challenge is the implementation and the pathway redesign that means that we can get the benefits. And just to mention a final thing there in technology, it is also about the funding and incentives. So again, very short-term funding, the same as what I said about capital, short-term funding envelopes. And what we hear again from a lot of technologists or people that are trying to invest in the NHS, in some instances, it might be a patient safety intervention again, but that if you can't generate and demonstrate in-year financial savings, then you won't get taken on. So again, that short-term horizon means we're not necessarily investing in things that could then have the greatest impact. Finally, on system leadership, the NHS, very compliance driven, that there's a lot of regulation and upward assurance, but that's not necessarily focusing on the thing that matters most, so not learning driven. And again, the short-termism that we see in terms of financial budgets, making in-year targets, but an inability then to plan for the longer term. A highly fragmented accountability, and that includes across provider organisations where normally productivity will sit with the finance lead, but ultimately, again, for productivity to happen, that has to involve things like transformation and clinical leadership, so it needs to have shared ownership. I'm not going to talk as much about weak commissioning capability, but again, constant restructuring means that we've never really cracked commissioning, and most countries haven't, but I think one of the main reasons for that, again, is constantly restructuring that tier. And then finally, we've spoken here about insufficient management and analytic capacity. What one stakeholder writes about this calls these force multipliers. But it comes back to this point that I made about capital underinvestment, that again, you really want to make sure that staff have everything that they can available and are supported from, say, operational support, and that we have the right data to really understand what's most important for patients. And it doesn't feel like we do that enough in healthcare at the moment. I put a quote here. Bart has spoken at one of our evidence events, so we're going to hear from him after this, of course. But I just think it's very important to recognise this as well, that often where that ends up, you've got leadership that have to set the direction, you've got very frontline staff that have to then put that into practice, but middle management really matters here, and those are the ones that really need to interpret the instructions from above and then convince and convey that to staff on the front line. So I think that's a part of the NHS we often underinvest in, and again, it comes back to the fact that we're undermanaged relative to other services. I'm conscious of time, so I'm just going to move on there to emerging areas for recommendations. I'll just say first, as a commission, what we're trying to do, and this is a very rough graphic that one of our co-chairs did. I don't know if this will make it into the final report, but I think it nicely illustrates what we want to do. Where we want to get, we're not trying to identify silver bullets. It's not that we want to say virtual wards are the thing that's going to improve productivity. Far more the space that we want to be in is understanding some of these barriers, because at the moment, what we've heard overwhelmingly across the Commission, when we hear from staff, from our call for evidence, when we speak to people, there are lots of great ideas and initiatives, a lot of things that we could do to improve healthcare. And that makes me feel very optimistic, I must say, about where the NHS can go. But at the moment, there are a lot of things that get in the way of that. So these unhelpful initiatives or forces that are pressing down on staff that are trying to do better. And what we want to do in terms of identifying policy reforms is to really think about what it is that we could change in the system that would then mean that all of you can make progress more quickly, more readily, that becomes easier. And then the sort of internal momentum of the system is towards that improvement in productivity. So one thing I would just say then is, I think I've maybe illustrated this already, a lot of the things that we hear across different domains are actually quite similar. So whether it's having unclear system objectives about what the actual value of the thing that we're trying to achieve, whether it's that misaligned incentives and short planning cycles, there is a lot of overlap in terms of the drivers that we've set out. And also, we can't just do actions in one area and hope that we can get away with something. It really does take coordinated action across all the different drivers in all of these barriers. I'm just going to bring up here some emerging areas for recommendations. Again, conscious of time, I don't want to talk in great depth about all of these, but maybe I just start with the first one. I think this point about communicating a clear North Star. So again, that pivot from understanding productivity simply as more activity to the outcomes the NHS is trying to achieve. Measurement here is actually very difficult. It's difficult to get a perfect measure of all the outcomes we want to achieve, but we should at least be able to communicate that and communicate that to staff. And that just means that everyone has a joint understanding. It picks up on the kind of the intrinsic motivation that so many people have to make improvements. So productivity doesn't get shoehorned into just driving more activity or making cost cuts. Productivity is not SIPs. It's not in your efficiencies. It's wider than that. And that has to be supported with more outcomes measurement. So again, a lot of the metrics and targets that we have are set against more activity. We think we need to build more use of proms, for example, which it grew but has sort of stalled somewhat. More use of proms, greater use of PREMs, patient experience as well as patient outcomes, so the system is more responsive to patients. Again, multi-year stability, I won't talk too much more about that, but again, having long-term settlements, investing in capability, I've already spoken about. I'll maybe just go on to the last one and say enabling a learning-driven high-trust culture. And again, this comes back to the point that we can't do this without elevating staff engagement and making staff engagement really at the core of what productivity is. I just want to end by saying that none of this is cost-free. If this was all easy, it would have happened already. So in some respects, it is being able to strike the right balance between some of these things. And I mean, one we typically hear, for example, some people you speak to will say that if we want to improve productivity, we just need to measure things really well and hammer people against measurement. But that really comes up against this point about having more autonomy, especially at a local level where, the people at the front line will be closer to understanding what matters for patients. So there is a tension there between how much measurement we want and really trying to create that learning system that's more responsive and responds to what people know and who has the sort of best information for that. There's a tension between, I've spoken about capability, but if you want to spend more on managers and other things, that would come at the expense of perhaps frontline capacity. So again, there's a tension to navigate there. I think there's something about standardization. It feels to us that there are lots of times in the NHS where we have quite thin capability for doing things, be that procurement or anything else, in local providers, and there maybe ought to be a way to try and pool that and help support each other, but that may come up against some local expertise and local solutions. And again, there's something about realism and the pace of improvement. So we've spoken about medium-term financial planning, and in some respects that should really be founded in what's a realistic plan for that area, but then that might come up against the desire to go faster and make improvements faster. And finally, I'm just going to touch on sort of value and activity again. And just to say, I mean, there are probably some services. I mean, an elective care, for example, high volume, low risk activity, where actually just getting more activity is a good thing. And again, theatre occupancy rates and so utilization rates, that can be a sound metric for getting better value. In other instances, it's more complex, and it's really things like end of life care, where I think it shouldn't be set against activity. It has to be an understanding of value, but that's likely to vary by the service area. So that's all I wanted to say now. And again, there's time for questions, and it'd be really good to hear back from you whether the things that I've mentioned actually resonate with you. Are there sort of areas of recommendations you agree with, or anything you don't and you think that we've missed? And what would need to change for you for productivity to become easier to realise? I think I'm out of time, so I'll stop there.
Thank you so much, Stephen. Lots there for us to think about. So on that note, I will hand over to our second speaker, which is Bart van Ark.
Good morning, and I hope you can hear me okay, and that you can actually see the slides that I'm going to present with you here this morning. And if I don't hear anything, I'm sure that I'll be okay. Yeah, very happy to be here. Really important to talk about this topic, but even more so to talk about it in a regional context. And I will argue that during my presentation, how critically important it is to think about productivity in a local or place-based concept. I always say productivity happens on the ground. You see it when a place is productive, when you enter a town or a place, but also when you enter an organization, you can quickly see if that organization is performing well, and that is very much related to productivity. So you need to see it on the ground, and therefore discussing these issues in a regional context, such as here in the Northwest, I think is really important. Let me say one or two words about the Productivity Institute, as the chair has asked us. We are a nationwide research institute. We operate across the UK. We're linked to 9 universities in the UK. And if people ask us what we do, I always say, well, we do pretty much everything under the sun on productivity, which ranges all the way from technology to people skills to regional development, as I just mentioned, to policy, but also very much to business engagement. And public sector productivity is a critical part of this. So we do a lot of research around public sector productivity generally. We have been focusing on some specific sectors. Notably, we've done a lot of work around the police, and I will share 1 or 2 insights from there. Also quite a bit of work around social care, which sometimes is an area when it comes to productivity that even gets less attention than it deserves, and given its relative importance for the overall healthcare system. So so we're very broad-based. We have about 80 researchers working with us, or associated with us in one way or another. We run 9 productivity forums across, again, in a regional context and for the devolved nations across the UK, where we bring a lot of these issues together. Just put in a little plug, Stephen did an excellent job in explaining the Health Foundation report that was published just a little earlier. We just recorded a podcast with the 2 co-authors there, Tara Allas and Anita Charlesworth, as well as Mark Britnell, which was just released this week. So if you go to the Productivity Institute website, or you just take the picture there, you can listen for about an hour to the authors, the co-authors who have been putting this work together. So that's just a little plug. But let me go into what I really want to talk about over the next 15 minutes or so. So let me basically start with what I think the key messages are, and everything you hear me say is very complementary to what Stephen has just been saying. So first of all, productivity opportunities are plentiful in healthcare services. That's really the good news. There is no shortage of ways to improve productivity. But we do believe that it is critical to systematically identify these opportunities across something that I call the delivery chain of healthcare service or public services in general. And I'll introduce that concept of delivery chain just in a second. It's critical that we think about this systematically, because there are many different drivers, as Steve has explained, and I will stick to the typology in the report on people, capital, technology, and transformation, or organizational change, I may perhaps want to call it. But these resources really only work in conjunction. You can't just, as Stephen rightly said, there's not a silver bullet. You have to really join up the resources in a right way to attack the opportunities that you're seeing ahead of you at different places in the delivery chain. That will immediately help you realize that there are synergies between these different drivers, but there are also trade-offs, which Stephen also just talked about at the end of his presentation. And these synergies and trade-offs, they exist, but they can be managed. They cannot always be overcome, but they can be managed. And just by identifying and be transparent around them helps us to find our way through those opportunities. It's not easy to do productivity anyway. It's particularly not easy in the public sector organization, as I will just say, explain a little bit more in a minute. But if we think about this more systematically, we can achieve a lot. And this is perhaps the most important message to management, is that take some time to think this through and to look systematically at what your opportunities are, and then see how you can manage the synergies and the trade-offs. So what I'm going to do is to say a few words about the broader perspective of productivity, because what the productivity challenges we are facing in healthcare are certainly not unique to the sector. That exists across the public sector, that exists across the economy. As Stephen said, that actually exists across many economies in the advanced world. I will then talk a little bit more about why is public and particularly healthcare sector productivity so important. I'll say a few words about measuring, but I'll focus most of my attention on the fourth subject here, which is how do we actually mobilize those resources in healthcare and in social care, by the way, to improve productivity. There are lots of slides here. I'm going to skip through them very quickly. I understand that the slides will be made available to you, and at any time, of course, you can reach out to us at the Productivity Institute if you have further questions or inquiries. Okay, so first of all, perhaps important to understand, and again, Stephen mentioned this earlier, we're not on our own when it comes to the slowdown in productivity. This is just a measure of the narrow productivity measure that Stephen talked about. This is just GDP per hour worked in various countries. The UK is right in the middle there, which is the dark blue line. The other country that stands out here is the US, which is the red line at the top. You see that pretty much everywhere, including the US, productivity has slowed down. But since 2020, since the pandemic, we actually see more what we call divergence happening. So the US has been doing pretty well in productivity since 2020, whereas most of the other countries, including the UK, are slowing. I just misspoke a minute ago by saying that the dark blue line in the middle was the UK. That's not true. That's the euro area. But just below that is a dark red line, and that is the UK. The UK actually is very close to the euro area average when it comes to labor productivity, but it is well below some of our peer countries like Germany and France, and only slightly ahead of countries like Italy and Spain. Now, we talk a lot about productivity growth. But the reason why I show this chart in the way I show it is because it shows you the level. It shows you the actual level of GDP per hour worked, and you can see the difference across countries. Why does the level matter? Because as I said at the beginning, you can see when a place has a high level of productivity. If it does, it supports the resilience in these places to deal with shocks, to limit the risks of low performance traps that exist across pockets of society. And this is and healthcare plays a key role in this aspect. The healthcare sector can be absolutely important to help countries, to help places to get out of these low productivity traps and improve their performance. Because this is just an average for those countries. But if you take the UK line there are some areas, London, the southeast, even some cities in the north, that are actually well above that average. But there are lots of regions that are below that average, and that are at productivity levels that I would call low productivity traps. And once you are in low productivity traps, it's very difficult for places to get out of this. You get then a sort of cumulative issue of problems that is affecting the healthcare system quite substantially as you go along. Lots of regional differences. You see that here as well. You see here on the horizontal, so from left to right, you see the least to the most productive places in levels. And then on the vertical, you see from bottom to top the least, the slowest growing to the fastest growing regions. And if you take the Northwest, which I highlighted there, Cumbria, Lancashire, Merseyside, Greater Manchester, you see that these places all have lower productivity levels than the UK average. Although some of them, certainly Greater Manchester, has actually been catching up a fair bit. So they're actually improving their performance in going forward. I'm going to skip through this because there's really no time and there's a lot of data here. But To Stephen's point, that narrow concept of productivity is really not the right way to look at things. You need to look much more broadly at indicators that relate to productivity. That includes, of course, the performance of the business community, but also skills and training and the role of policy institutions, and also critically the role of health and well-being in the system, which is, of course, our focus here today. And as I said, I'm going to skip through these slides. But I think the main takeaway from this first segment really is that I strongly agree with Stephen that even though we do a lot of work around these narrow measures of GDP per hour worked and labor productivity, if we really want to get our arms around what is happening in our economy with productivity, we need to think about how do we optimally use and combine these resources that we have available, whether it is people or whether it is capital or whether it's technology. How do we optimally combine them to create better outcomes for people, for firms, and for the economy? And if you take that concept, then the healthcare sector is very much a part of this story, as many other sectors in the economy are. So why does public sector productivity then matter? Again, I'm going to go through this fairly quickly. Lots of data here, but it's 20% of our economy. It's about 17.5% of employment. It's 40% of spending. This is the public sector as a whole, not just healthcare, of course. It delivers, of course, the kind of services that are not sufficiently provided by the private sector, or sometimes not effectively provided by the private sector. And it is very important for the private sector, whether it is defense or trade or construction, but also health is a critical service, or education, a critical service on which the private sector is depending. So public sector productivity helps the private sector, but it's also vital, of course, for our living standards and for well-being. Now, let's pause a minute here and just talk about why is public sector productivity so difficult? Why is it such a difficult topic to think about? And again, I use slightly different words than Stephen, but I think we're very much aligned in the way that we're thinking about it. First of all, economists talk about a concept that we call the Baumol's cost disease. Baumol was an economist a couple of decades ago who said, look, we have this problem that the economy consists out of many different sectors. And some sectors like manufacturing or business services, they have very high productivity growth. But we see a rising demand in sectors that actually are not so productive, or that don't grow productivity that rapidly. They're more labor intensive, they use more labor relative to capital, and that is certainly true for health and for education. And as countries become more advanced, these services become more important. So it's almost natural, if countries get more advanced, that these low productivity services are becoming more important. Doesn't mean that productivity cannot be done in those sectors. It just means that it becomes a larger share of the economy, and therefore we need to think about it much harder, how we can sort of mitigate the effects of these low productivity factors. It should not be the objective of the healthcare sector to be as productive as possible. It should be the objective of the healthcare sector to use their resources as efficiently and effectively as possible to create better outcomes for people. Public sectors are very complex organizational structures. We would compare them typically with what you might call a multi-product firm, where you produce many different types of products. And not only are these products all separate, but they're also very much connected to each other. If you think about when people experience healthcare, they have to experience different parts of the healthcare system in order to get a better outcome, whether it's the GP or whether it's the hospital or whether it's the social care. It all needs to be connected up. So it's extremely complex organizational structures, and that makes productivity very hard to manage. Governance structures in public services generally are very complicated for the right reasons. They're sometimes democratic, but that slows down the decision making and implementation. There is a culture in these organizations to do well for the customer, and sometimes that goes at the cost of doing well for the effectiveness of the services that we're going to deliver. So this continuous challenge between making sure you give the best tailored, customized product to the patient versus the need to make sure that the organization becomes so effective as possible in order to provide as many of those opportunities is really important. Fifthly, the public sector has been driven for a long time by this new concept of new public management, very popular in the 1990s and the 2000s. And honestly, that has given a lot of efficiency drives and gains that were necessary in the public sector. Not everything about the new public management movement was bad. If you look at the statistics, you can actually see that productivity in the narrow, but even in the broader sense, adjusted for quality, did deliver results. But it's sort of hitting its limit. At some point, we were, the targets became more important than the actual effectiveness, or we're missing the real outcomes. And we're now really rethinking the way that we need to think about public management of the public sector. And then finally, of course, there's a lot that we can do to improve this. Despite these complexities, technology has a major opportunity, but only if we have a better knowledge of the delivery chain, if there are better ways of measuring this, and if we create incentive structures that help us to really get a more strategic focus. Now, let's then go and talk about the delivery chain, because I brought that up as a really important concept to talk about this morning. So this is a typical example of a delivery chain, and this was developed originally actually by a group of government officials back in the mid-2010s, but has been developed over time to think about productivity all the way from the budget, the public money, the public funding that is available for that service, all the way to the desired outcomes. And you can basically see there are a couple of steps there. The first step is that if we have a budget, we need to turn that into inputs. And there are lots of questions there where we can actually have massive productivity gains. We sometimes call them budget efficiency. How can we get to our highest quality inputs as effectively and as cost effectively as possible, but also make sure that they are as effectively delivered as possible? So lots of opportunities in that first segment that quite often get overlooked. In the middle is what we call maybe the somewhat narrower concept of productivity. It's the organizational productivity. It's the efficiency of the organization. That is, once we have those inputs, how do we combine them in order to turn them into the better outputs? And the outputs are basically here, as Stephen has already explained, any kind of measurable activity that you're undertaking. But then if you all the way go to the right, then of course at the end, that output needs to deliver as an outcome. It needs to lead to healthier patients. It needs to bring less people back into the healthcare sector so that they can lead healthier lives, and so on and so forth. And again, across all these areas, you can see massive productivity gains happening. Quite often we hear policymakers or politicians talk about we need to increase value for money. Well, value for money is just looking from public budget to desired outcomes, but it sort of hides all these opportunities that you have in the middle. So if you think about systematic thinking around where productivity opportunities are, you have to begin to own this concept of the delivery chain for your organization. Many organizations have multiple delivery chains that sometimes interact, that sometimes have trade-offs, but you need to deal with those challenges. Also, very importantly, across this delivery chain, as I said, many productivity opportunities. Some of these opportunities are basically related to improving task performance. You do something and you just can do it better by using technology or by training people or by putting some capital to it. But another part of this is what we say is changing the case mix. And that really has to do with the fact you're going to do different things because the technology or the capital allows you to actually stop certain activities and do other activities and give them more attention. So a very good example of changing case mix, of course, is if GPs are working very productively and effectively, it would reduce the case mix that goes into the hospitals, because we would only have to bring the more serious cases into the hospitals because we can manage prevention and relatively simple cases at the GP level. So again, this is sort of systemic thinking. It may sound a bit boring, but management is about systemic thinking and seeing where these opportunities are and how we can manage these opportunities going forward. I'm watching the time, so I'm going to skip the whole thing about measuring public sector productivity, because actually Stephen has spoken about this very effectively, and finish my last few minutes on mobilizing public sector productivity. So again, the four key areas: technology, investment, people, organization. I'm going to start with technology, not necessarily because I think that's the most important thing. Sometimes that's been suggested as being the most important thing. But I do think that technology is a sort of impetus that actually creates a lot of incentive and opportunity to make other changes. So there's lots of technology available, but the digital part of technology is probably leading at the moment. There's loads of potential here, but very challenging to realize, because one thing is to have the technology available, but the other thing is to then actually make that technology work within the context, within the organizational setting that you're having. Particularly artificial intelligence, of course, is now a big deal. Government is talking about that a lot. We can pick it up a little bit during the discussion if you like. A lot of the excitement there is about artificial intelligence at the front end of the delivery chain. So, better treatments and all those kind of things. And that are really, really important. But AI and digital transformation generally is still hugely under-leveraged at the back end of at the beginning of the delivery chain, where there is massive opportunity to improve processes in order to let these resources flow more efficiently through the system. So streamlining internal processes and using AI to resolve all sorts of information bottlenecks in the organization is actually the critical opportunity. Stephen has talked very extensively about capital. I think it is absolutely critical to understand that we have had a serious shortfall in capital investment in the healthcare service, in the NHS, and catching up on that is going to be very, very important to make any of these any of these new technologies important in going forward. Also, scale is key to capital. So we need to think about how can we scale up the initiatives, collaborate better across organizations. The people factor, creating an organization where people can be focused on continuous learning and continuous improvement to identify these digital opportunities and make them work is obviously very important. And then finally, there's the transformation effect, adaptive organization. And again, because of time, I'm going to skip through this fairly quickly. Just looking, because I'm essentially over my time, so I think I'm going to skip all this. And just want to identify one thing around systemic management, and then I'll wrap up and hope we can pick up a little bit more on the discussion. One of the critical factors in managing these kind of opportunities, as I said, it's a complex system of management, identifying the opportunities, managing them, identifying where the opportunities are, and then dealing with the synergies and the trade-offs between the technology, between people, between the capital investments that need to be made. There's just a lot going on. And changing is very, very difficult. And managing that change management is very, very hard. One, again, very good way of working systematically around this is what we call a management theory of constraints. And that is basically to begin, once you have identified these opportunities, to prioritize what is most important. Where is the biggest constraint? Compare it with a pipeline, with a bottleneck in it. You want to begin where the bottleneck is the biggest, because only if you can resolve that bottleneck, the opportunities will flow more easily through the organization. And then you can identify the next bottleneck. Now, this is an iterative process. It requires a lot of careful systematic management. Stephen made the point that I've made before about the role of middle management in this respect, because they're actually the ones who are quite often best placed to understand where are the priorities of the organization versus where are the bottlenecks in order to implement this. And we think, therefore, that such a kind of approach to management can really help us to work ourselves through this very complex system. Let me stop here. A lot more things to talk about. There is when we share the slide deck, there are various resources at the Productivity Institute that can be shared with you on this. But to keep the meeting on time, let's hand over and hope that we can pick up some of this during our discussion. Thank you.
Thanks so much, Bart. Lots and lots of information there for everyone to look at and digest. So I've noticed there's no comments at the moment in the chat. So what we'll do is take any comments, questions, etc. at the end. So please put your comments and questions in the chat, and we'll pick them up as part of the panel discussion shortly. So on that note, I'll hand over to our final speaker, who will share some practical experience around sustainability, productivity and practice. So I'll hand over to James.
Thank you, Louise, and thank you, Stephen. But that was a fascinating insight. I think drilling down into one of those key areas around digital and innovation through my segment. But first, as Louise asked, just introduce myself a little bit more. So I'm 22 years NHS clinical background. Spent most of my life in the NHS as a paramedic on the front line and through COVID, and found myself on this digital journey as a result of COVID. And for as much as COVID was a time of great uncertainty, and as we saw that huge productivity drop off, it was also, interestingly, a time where digital and innovation really did flourish. And that's where I found myself in this position where I find myself now, talking to you wonderful people about the experience. And why did it flourish? Again, we talk about the barriers and some of the challenges to productivity. My experience with that was that it was about operational delivery in the context of something that we'd never faced before as a system. And that straight away stripped out so much of the bureaucracy. So many of those barriers were lifted. And from a digital perspective, I know that at my time at Yorkshire Ambulance Service during COVID, we were able to do things on an innovation scale like never before. And that got me thinking, really, and is what led me into the position that I'm in today is how do we take the lessons that we learned from that time, and how do we take some of these barriers and the challenges and what we've learned, what the system's told us, and how do we model that for a future? There's been so many interesting comments made by Stephen and Bart. I don't think time's going to allow me to reference these in what I'm going to present. But I'll give you, from my perspective, a lot of what that data that the guys have shared, and share from a very a narrow vision of digital and specifically around automation, and where we see that going. Now, everyone will know that automation features so heavily. Interestingly, it makes up such a great part of the 10-year plan. We've seen the short and the mid-term planning documentation, the implementation now, that the implementation plans talk so much about automation. And we're hearing this week of another funding initiative from the Department of Health and Social Care, around 7.7 billion pounds that's going to be pumped into the system over 7 programs in the next 5-6 years. And automation again is going to feature so heavily in that. But have we got that right? And I asked that question because I think it was Stephen that talked about the silver bullet. Back in 2020, when funding streams like the TIF and the Unified Tech Fund were stood up, automation was really talked about as a silver bullet. It was going to fix so many of these productivity challenges, both in clinical and non-clinical environments. And where are we 6 years after that? Well, I'll talk a little bit further about that shortly as we go on. But first, let me just tell you the experience that my team has had. Christine, if we could just have the next slide, please, that'd be great. So my team began back in 2020. We were initially set up as a centre of excellence for automation by funding from NHS at the time. That was under the TIF. Many people may remember that, the Technology Investment Fund that pumped again hundreds of millions of pounds into the system to try and improve the digital infrastructure landscape. Now, we were stood up to try and promote the use of automation, and we've done that effectively, but have we done that at scale? We've done that across 50 NHS trusts. We've supported the development, the design, and the operational support of hundreds of process flows, creating thousands of RPAs to deliver an output which we're really proud of and has been award-winning. But I'm still stopped and asked every day that how is that contribution of around 300 whole-time equivalents that were delivered in that 5-year program of work, which is not insignificant, how has that helped the system? And the answer to that question that I'm often asked comes as a surprise to many people, and I'll give the answer to that at the end. So what did we? Let's just hone in on one of these initiatives. We could just have the next slide, please. So this is just an isolated snapshot of where automation landed. This was after the Unified Tech Fund of 2022, where again, I think around 600 million pounds was pumped in of Treasury money into the digital landscape to try and improve things across a number of sectors and service lines. Now, we delivered a number of processes, as we've said, across a number of trusts as part of that Unified Tech Fund. But the benefit and the realization and the operational challenge of delivering that was, in my view, insurmountable. Very interesting when we compare the private sector and the public sector, and again, this speaks so much to what the guys have already shared in data, that how is it that as a public sector body, we cannot get an ROI on investment in technology and digital versus the private sector, sorry, which will do that, according to Gartner, in a relatively short period of time. And yet the reality of it is, for us, with some organisations and trusts we work with, over 3-5-year programmes of work still didn't achieve an ROI with the technology. A lot of that was down to utilisation and internal resource. So as you can see there, at the height of our programme against the Unified Tech Fund, we had 169 digital workers. There's 1.3 million hours of resource. They were sat idle. And that's quite shocking. That's more than £3 million of annual license spend, and that was only across a small number of trusts that we were working with at the time. So the data's not fully system-wide, but it's still representative of what we know the challenge to automation has been. Drill down into that even further. When you look at organisations with automation capability, we found through the trust that we work with that very few of them were maximising more than 20%. In fact, we've recently done some modelling just in the back end of last year for a small mental health trust in London, who were only using less than 1% of the capacity of that digital workforce that they paid for on an annual basis. That meant of those 3 processes that they had live, that was costing them £385 an hour to deliver that automation. Obviously, they could have had a lot more workforce doing that for that cost than underutilized. So how do we change that? How do we move on from that? The biggest single challenge for us, as we've seen in the NHS, is the thing that we all recognise, that we all accept is the biggest challenge, is the silo way of working, the fragmented landscape on which we work. Automation could have been that silver bullet. It could have given great productivity gains had there been standardization across the landscape. And I'll talk in a moment about one of the most successful use cases that my team have been involved with, and the gains and the benefits that have come from it, from using automation in that, what Bart just described as that regional context, which is the right way to do it. So perhaps if we just nip onto the next slide, please. So this is something that I call the power of once, and this is something that the London region are really focusing on and are setting a real positive example with this. And this is around shared service. Now, if you've got any chief people officers, any senior HR people, will know that transforming people services is a huge program of work that's about to launch across the system. And this will see the creation of 7 shared services in and around some transactional HR and recruitment. But for the past 5 years, we've been automating the shared service for the London region, the North London shared service and recruitment. The challenge that these 10 organisations have had have been noteworthy, but again, the lessons that have been learned are very, very powerful and very well documented. So they were very much a corporate service programme that focused on the removal of duplication. I mean, many people may remember back in 2019 or maybe 16, Lord Carter's report of removing unwarranted variation from the system. This is what this programme of shared service provision in recruitment aimed to do, this process standardisation, which then gave the perfect blueprint on which automation could be placed. And again, this goes back to that single biggest reason where we've seen automation fail across the system, is that lack of standardization. Where process is unified, where it's simplified, where it's leanified as much as it can, automation stands the greatest opportunity of being able to provide an increase in productivity. That's not only from your standard deterministic automation, that also, I think, very much underpins the guardrail for AI. Bart talked there about this use of, and we know that there are big pieces of work being done at the minute by Amazon and others around producing an agentic hospital, focusing on corporate services and clinical services. But again, I question that without that standardization of process across the system, can even AI be that silver bullet as RPA promised to be 6 or 7 years ago? I would question that and be interested in people's opinion on that. But again, this then comes down to leveraging economies of scale. So in the current context of automation, can we have an economy of scale? We can't. The blueprint is there. And I'll give an example of that. So we look at Microsoft Power Platform. It's a huge level of investment by NHS and England into Microsoft tools. We have a central spine of brilliant solutions on the Power Platform. But are we using that effectively at scale across the system? In fact, one of the guys talked earlier about supplier-led market, how we have these systems dropped into our environments, into our trust, into the region, into the system, and we're not supported to use them effectively. And I firmly believe, with my experience, Microsoft Power Platform is another one of those systems that's been given to us on the central tenant or local tenant, and we are not utilising, and we're certainly not maximising the capabilities and the efficiencies that could be brought from that technology. So how do we plug that gap? Just the next slide, please. So some of the benefits of this shared service approach, and again, we talk about the quantitative benefits. There's a whole host of qualitative benefits that come along with this as well. Again, time won't really allow, but we'll talk about the highlights and the benefits of having this once for a region approach and the increase in productivity that we see. So currently across the NHS, the standard recruitment time to bring somebody new from advert through to joining is around 300 minutes. Under that shared service model in North London, we've reduced that by a third to 200 minutes. That's a huge saving. The net effect of that is it's brought down the time to hire by 12 days from a national average of around 30 to 35. Again, the model proves itself. As part of that, the data accuracy that we see is improved from 70% to 99% through the simple use of things like digital e-forms. And my team have automated now, I think it's approaching 150,000 e-forms. This data is a little bit out of date now. But again, seeing the improvement of that input from a new starter, taking historically 11 days to submit a form, now through to 3 days through a full automated end-to-end process, the results speak for itself. We've had direct impact onto managers, 2,000 hours a year, just by doing something simple, one simple process of updating appraisal data into ESR. Such a clunky process, as many managers will know, but the automation of that across the shared service has allowed us to free up 2,000 hours of manager time. That is a huge productivity gain. But again, only a productivity gain that's been possible through standardization of those processes. How big was that standardization piece of work? I missed this from a previous slide, unfortunately. But when we first sat down and did the baselining across those 10 organizations, we identified through that research piece 6,000 variations. Now, I'll just leave that to hang for a minute. 6,000 variations in just recruitment process across 10 organizations. That was in templates, policies, the way that people enacted those policies. The end-to-end process contains 6,000 variation. That was one work stream. And obviously it took years for us to get through the standardization work, but ultimately now the benefits are being seen both financially and operationally across that. And obviously that's now something that's set to scale through the system as a result. So how do we change, and how do we fix this? Again, the guys gave some interesting answers as to how we move forward with this. For me, it's very much about sweating the assets that we already have. We are, as a system, the NHS, we are a digital and technology magpie. We see something new and we respond to it. We run after it in full pace. We onboard it before we're digitally mature, digitally ready to be able to do it. There are lessons to be learned across the rest of the public sector, the way that the Home Office, for example, have onboarded the use of Power Platform across its entire architecture and the benefits that they release from doing that. We're challenged. the 650 organisations that make up the NHS, not including GP surgeries, there is only one thing that we carry as a standard across all of those organisations, and then that's our vision to help people and the logo. Everything else is a variation and a nuance. So how do we use digital in the architecture and the network and the landscape that we have now to increase productivity? Somebody mentioned earlier, it's not about a complete system redesign. I would love to explore that in our mind from digital. How do we connect? How do we challenge and overcome this interoperability challenge? For me, when working across a region, real world example, why do we have to do a DPIA 10 times for a process that we're trying to get as a collaboration? Why do we have to do a DCB 160 over and over again to achieve? This is about very much regional working, removing some of those barriers. Can we move them? I think one of the guys again said earlier that this is not, the barriers are systemic, not structural. I think from digital, we have some structural barriers. Absolutely, we do, that need to be overcome, but it is systemic. And I think the shared service model that we've seen has proven that with the coalition of the willing, that system can be used effectively and it can collaborate effectively, and digital really can and is increasing that productivity gain. There are definitely lessons to be learned from it, and again, love to explore that in the Q&A. That's all I've got for you now. Thank you.
Thanks, James. So we're going to move on to a panel discussion. We've got approximately 30 minutes or so to do this. We're really keen for your comments, questions, etc. So we have got a couple of questions in the chat for our panel. There's quite a detailed one there from Grenville Page, if our panel can see that. Just so wish to ask and get views in the context of NHS 10-year plan, 3 shifts, neighbourhood health, AFTs and IHOs, etc. Would anyone like to take first go of that detailed question?
Can I come in on that?
Yeah, of course.
So I'd say a number of things. I think foremost is what I mentioned about North Star. So what is it that neighbourhood teams are trying to achieve? And I don't think that's been well described to this point. So again, having that shared vision for what the NHS is trying to achieve, I think is fundamental to getting that shared working. Because ultimately, if you are going to be making trade-offs or shifting resources between parts of the service, I think we need to understand what's the joint goal that we're all trying to achieve. And again, articulating, measuring, that's really important. So again, measurement's part of the picture as well. Especially for neighbourhoods, this isn't just going to be about driving more activity. It is about understanding what the outcomes the services is trying to achieve. And again, I think we need better measurement and understanding of outcomes to help drive that. But what I say, from people that we've spoken to, I think where you see good leadership in organisations, you do tend to see there's a tendency to look out and to really try and understand first, yes, is our service performing well? As a provider, are we performing well? But there's a limit to that. And at some point you do then want to ask, if you're an acute provider, how can we support the community and so on? But again, it is having that attitude and understanding that the whole system matters, but it's the maturity and the quality of leadership that needs to stand behind that. And I think we can't move faster than that, the maturity in the system, as it were. And obviously that is the approach now with the 10-year plan, is to identify those areas that maybe aren't performing best and have them pilot IHOs and so on. And I do think, again, that point about piloting and learning about what works, rather than trying to get everybody on become an IHO, next year, as it were. It's that pace of improvement and understanding, where organisations are and building on that. I think the 3 things that I've said there about understanding what the North Star, getting the measurement behind that, and then having the maturity in the system to look out and understand how to work best with partners.
Thanks, Stephen. Any other further comments from our panel on that, or are you okay if I move on to the next question? Yeah, I'll take that as we'll move on to the next question. Okay.
It's been a big question. I don't know if Grenville wants to come back in as well, if that covers everything. Okay. I mean, helpful to get any feedback or thoughts if she might have any.
Yes, please. Thank you. I'm a non-exec at the Christie, and I also chair Viaduct Care, which is a GP federation in Stockport. So although I'm an accountant by background, I have a real interest in that whole pathway from the community right into acute, into the specialist providers. And one of the things that I think is absolutely essential if we are going to realise the ambitions, the 3-shift ambitions, is a real cultural shift and a behavioural shift about collaborative working, not only within the NHS, but in the community, with the volunteering community sector, with housing providers. And we just need to create a new reality. There's lots of great stuff being done, but we are nowhere near using the full potential of those other non-statutory bodies like housing providers, the volunteering community sector, education and schools around what they can contribute. There's issues about we need to get a lot more innovative and trusting in how we commission, so we really leverage the full potential of those organisations, which are essential around those early interventions and prevention to reduce the unnecessary flows into A&E and hospitals. And that's a key area for them releasing opportunities in the hospitals around productivity gains. We need to address the governance and the 30 years of the market that has basically rewarded activity in hospitals, and change that culture where, so if you take, for example, you look at the cancer pathway, it really becomes joined up and the specialists have greater influence and levers to drive innovation in the primary care and the psychological support settings. So, you know, I think the plans are very ambitious and inspirational, but we need to address some of these barriers that you've talked about around organisational constitutions, performance regimes, how the money flows, to actually realise, and at the end of the day, to give a much better deal to the people that we're serving that are based solely on that, as opposed to the organisational silos and the narrow interests of particular parties. And I think that is the challenge that we've got around that.
Thanks so much, Grenville. Lots there to think about. Got a question from Anne-Marie. How can the NHS address the middle management gap to provide leadership capacity to drive forward and engage with staff on productivity, given the recent drive to reduce management costs?
I'm happy, if that's okay, to pick up on that one, because it's one that I'm particularly passionate about, and Stephen mentioned it earlier, and I reiterated it also when I made my introductory remarks. And it relates a little bit back to the previous comments that were made, and also what James talked about when it came to the importance of standardization. The question, I think, of all of this, where do we start, right? Because there's just so much happening that needs to be changed. And when I was talking about this theory of constraints, you know, how can we systematically identify most important management bottlenecks? I remember that once I talked to a similar audience in healthcare, like here, and I made this point, and somebody raised their hand and says, well, that's very nice of you to say, but we just can't prioritize. We literally cannot prioritize, because that's not the way we work. The way we work is that every day we have 100 problems to come to us. And yes, we can do some triage and all those kind of things, but it keeps adding more and more and more. So how can we systematically work around this? And, you know, that's, I think, such a critical issue where the role of middle management is going to come in, because senior management can develop a very easy, clear view about where we should start. AI is a fantastic opportunity to prioritize, because it will actually resolve a lot of the bottlenecks. However, to James's point, it needs to be standardized, it needs to be shared across different services, and that immediately translates the problem back to the middle management that needs to actually make these kind of alignments between different types of organizations. But we also have to realize that middle management does not only have the pressure from the top, it also has the pressure from the bottom, because the people who are out there working with the patients day in, day out have their own experience and their own pressures, and quite often feel that they're not being heard. It goes to the question about the recent drive to reduce management cost. You hear that a lot in the sector, and that is that, yes, there's just so much going on and it's only more budget cuts. Productivity, we don't even want to talk about it because productivity means budget cuts. So even the narrative around it isn't yet fully developed. Now, middle management can play an absolutely critical role in this. And I think finding opportunities to give middle management time to think about what the opportunities within their organizations are, what the collaborative opportunities are across the delivery chain or with other organizations within the region is one way to really go about this. And I think making it possible for middle management to do that kind of thing is going to be a very critical part of the solution here, not to try and change everything, but to prioritize.
Thanks so much, Bart. We've got Daniel's posed 5 questions in the chat and asked me to pick the most appealing. I'll pick one, and then I'll touch base with Daniel to see if there's anything else he wants us to pick. So, what are the most common mistakes organisations make when trying to translate this into frontline operational change? Who wants to pick that up from our panel?
I was wondering if James wanted to give on the frontline perspective, but maybe that's
Yeah, no, it's a great question. I was just musing that how I can bring that from a digital perspective. That for me, I think the most common mistake that we see across the landscape is the fact that digital has the answers to everything, and technology is going to be the thing that creates the biggest productivity increase. And again, I see often the complete opposite of that. It's not people-centric enough. Very often when things are done from a digital perspective, it is done, I think someone else has mentioned about using the right language, it's done top-down. Where I've seen the most effective use of automation and digital tools is where it's done from a completely transverse triangle, it's done bottom-up. I'll give Northampton as an example. So the Northampton Automation Accelerator, they created an app to request everybody in the organisation across Northampton General Hospital to think of ideas that were going to improve productivity and efficiency at a staff level. And in the short space of a few weeks, they received over 500 suggestions from frontline staff of how to make improvement and bring in this change through digital. And they were prioritised and they were worked through and they were operationalised, and they had massive impact in and around the COVID recovery and also in and around elective recovery. But that was because the right people, the right stakeholders were involved. I think for me, the most common mistake that organisations make is not doing that, is not involving the right stakeholders at the right time in that journey. And ultimately, it's your SMEs, it's those stakeholders that will make a solution live or die. They will work with it or they'll work against it. So for me, making sure that the right people are involved is absolutely critical.
I'd like to share, I so much agree with this. I'd like to share an example from the work that we've been doing in social care. As I mentioned earlier, we did a lot of research around it. And, if you're working in hospitals and so on, then that's when it comes to technology applications, a paradise compared to what it is in social care. Now, one case of technology we saw in social care was the use of a better scheduling tool that would make it possible for care workers to allocate their time more efficiently so that they were reducing their travel time to spend more time with patients. Sounds great, seemed to work very fine. The only thing that the app actually didn't really think about is to say, how do we make sure that the customer, the patient, gets to see the same person as often as possible? So the system ended up with multiple people, every day somebody else arriving on your doorstep. And that was realized too late, but it was captured because the feedback from bottom up, from the people who were actually out there, doing the work, was being captured. It turned out to be an issue that could be resolved by the technology. So you get the interaction between people and technology and organization to make this work, so that we will make sure that that scheduling tool was also allowing to make sure that the same care worker could spend as much as time with each of those individual patients. So it's quite often that kind of simple stuff that tends to get forgotten. And we're in an area of experimentation, so it's not the end of the world, but we need to have systems in place to make these kind of corrections so that we can learn, so that we can quickly adapt to that, and not then quickly end up into a system where we say, well, but that's the way the app is set up, and it will take half a year before we can actually change it. Those are the kind of things that we can do in order to make things working. Experimentation is critically important. Sharing user experience, whether it's from people who are actually on the ground there or from the patients or the customers, is really, really important. Thank you.
I'm going to ask another question that Anne-Marie's posed. We may come back to the other questions that Daniel's raised, only because they've had a number of thumbs up. So I assume quite a number of people would quite like that question asked. How do we frame the productivity challenge in a way with language that connects with our staff? It's often seen as something that's just discussed at senior level.
And I wonder if we set out in the slides there earlier and so on, and speaking about this, that ultimately productivity is about getting the best outcomes for the money that's going in. I mean, it strikes me from our call for evidence, we heard a lot from frontline staff, that everyone does intrinsically care about that, and that should resonate, or does resonate with certainly a lot of the NHS. I guess the challenge, and we've had this pushback. I mean, sometimes, should we be speaking about productivity at all? Should we only speak about value and getting outcomes? And perhaps sometimes when you just do pursue good outcomes and you pursue, also I think the question before asked about what you'd measure, if you have a very engaged staff and you're trying to improve outcomes, chances are productivity will follow. The only thing, we have had some pushback on that as well, where again, we do care to some extent about how much something costs, because we do care about the fact that the resources that go into one place, if we can save money, it's not that we're taking money out, it's that resource can then be used on the next person and on the next patient. So I do think productivity in itself is important, thinking about both those things, but again, that it should be centered as far as possible on value and outcomes. And even when we're thinking about efficiency, again, the reason why we want to get efficiency is to achieve better outcomes. And if a staff member sees an efficiency or what looks like an efficiency and says, no, hold on, this won't make the improvement. I mean, Bart's example is a really nice one. There's a real tension between, for example, in general practice, there's such an onus now on access as being the thing, but we know how important continuity of care is as well, and how important that is, especially to some patient groups for more complex conditions. So that shouldn't get lost. Ultimately, we should make a decision about what's most valuable, not what's only more sufficient.
So we do a lot of executive education on what we call strategic productivity. So it's around working with organizations, both private and public. I would love to do one for the NHS, by the way, around what does strategic productivity mean? And I spent the first day on only one thing, which is what's your narrative? What's your story around productivity, right? So start with a simple word cloud and say, what is the first thing that comes up when you think about the word productivity? You'll see it's all over the place. I've done this multiple times. It goes all the way from burnout and stress and cost reductions to the positive end, where people say, if we do this right, we can really use our resources much more effectively to create better outcomes. That's the beginning of a conversation. If you do that in your organization with everybody involved, not just the senior leadership, but also the people on the ground who come in and say, productivity, I don't want to have anything to do with it. I've been in meetings recently where people say, yes, we can talk about productivity, but I don't want to hear the word cost efficiency. And I said, well, if you don't want to hear the word, then there's no point to have the discussion. It's part of the story. It has to be part of the narrative, but the narrative is more than that. So narrative is really important. That's where culture change starts, is that people start to embrace why this is really important and why it can create better outcomes. Then we can begin to say the next step is, okay, and where are our biggest problems now and where are our biggest opportunities? With that technology, as much as it creates a lot of issues, it is a very important impetus to get change going, but it requires a lot of other things in the organization. So narrative is where this starts. Otherwise, the culture change is going to be impossible.
Can I jump on back to that as well? I think it's around leadership as well for me. So we talk about the senior levels, but it's about creating a culture of accessible leadership and the language. If you look at the challenge of a change curve, what is it that makes change effective? It's when leaders have the ability to be able to take everybody on that journey with them. And so where we see organizations failing with that, then there's got to be that internalized view. I think a lot of times as senior leaders, we stand looking through a window when we should be looking in a mirror. And actually, if an organization's really struggling to make gains, well, where is the failure of that? Is it the system? Is it the solutions? Is it the technology? Is it the pathways? Or is it the fact that leadership's just not inspiring people to follow that change curve? And I see that, I see that in organizations, for example, Chase Farm, which is a HIMSS 7 digital organization. You look at the results of the NHS survey for that organization. Is there a generalized positive morale in that organization? I don't have the data, I'm asking the question. It would be interesting to see. But that tells us that the leadership there has got that approach to how it onboards technology and innovation the right way. Does that positively impact the workforce? I think that's a question that we need to ask. But ultimately, for me, this is about making leadership accessible. I talked in my slides about the coalition of the willing. Some of the most digitally advanced trusts that are doing some of the most exciting things have accessible leadership. And that to me is a real critical and key enabler.
Thank you, James. I'm just going to follow on that. Anne-Marie, do you want to come in?
Yeah, I was just going to come in there because I think Hannah's put a point in the chat there about that very thing, and it's about increasing people's understanding and how we managers and everybody needs to bring it into the day-to-day conversations, so it's not this thing that's done to, it's just part of the daily culture. And I think that's just a really interesting point there made by Hannah.
Thanks, Anne-Marie. And I was just going to follow that up. Sarah's made asked a question about silo work and prevent us from achieving improved productivity. Does that link through to that leadership and engagement, and I suppose how you get that system level productivity as well?
Look at the comment that Ming Tang made talking about the FDP recently. It was a contentious comment, but she made the comment that the biggest barrier to the adoption of technology and innovation is ego. And so if we look at regional working, which has got to be the right footprint and the right blueprint for this, again, we have to stand and look in front of a mirror and be really honest with ourselves. What is standing in the way of these productivity gains? Is it the system? Is it the solutions or the technology or the people? Or is it me as that person that should be that enabler for this?
Thanks.
Go ahead, Stephen.
I was going to say, I mean, just to build on that point, I mean, it is that, outward looking. And again, where you see good leaders, they do that, they are looking out. And so the question isn't, what can I do and what can I build here? But if you've got a particular barrier or something, where else has done this? Where else has overcome this? Where else has seen a reduction in this particular, can you look for examples elsewhere? And that may be within your region, it may be beyond that, for where success has happened, and looking out before you start to rebuild something.
So two comments. One is following up. The other one is emphasizing another matter. So first of all, I was so struck by the ego comment and the importance of leadership. When we do our strategic productivity work and we talk about all these levers, people and skills and technology and all these things, then quite often management and leadership comes up as sort of the dominant, the uber kind of most important lever. And yes, that's all true. Of course, that is all true. It critically matters. But the ego factor is important. Good leaders also have a tendency to develop egos. A good question for a leader always is to ask, if I'm not there tomorrow, will this organization continue to operate in the way that it should? That means that I've made myself unnecessary. I've handed off. I've been able to empower the rest of my organization to take it forward. So a very important part of leadership is to make sure about how can I make myself smaller so that the rest of the organization is going to take it forward. So I think that's a critical part of leadership training that we shouldn't forget. I've seen too many organizations with big ego leaders, and then when they left, the whole thing fell apart and we started all over again. The other thing is to actually move the discussion a little bit, because as much as I agree, and I'm emphasizing the importance of culture and management and leadership, there is the issue around the organization, the complexity of the organizational structure of the NHS as a whole and the individual parts of the system as well. And of course, James talked extensively about, one possible ways to cut through that with shared services and all those kind of things. I do think that we need to continue also from the sector to work on the policy and political leadership to make sure that we put the right levers in place to make sure that the decisions that are taken in Westminster and Whitehall are actually going to be implemented in a way that people are beginning to own it, that the top down gets connected to the bottom up. I think that is really important, and I've seen some positive signs from government, not always, not every day, but this week we had a May's lecture from the Chancellor, for example, really emphasizing the importance of devolution here, not just in the healthcare system, but more broadly also. And I think the devolution, to make sure that we get a lot of that sort of decision making happening at a place-based level, where certainly in the healthcare system organizations can work better together, is really, really important. And I think we have to continue to work on our political leadership to make sure that that kind of devolution is going to happen, because we can't centralize all that. Having said that, once you have that power, you also need then to immediately begin to think about how can we scale it up. This is the challenge, right? So on the one hand, we want devolution. On the other hand, if you get that responsibility, you have then to think, how does collaboration lead to scaling up and productivity gains? That's where the concept of shared services come in. That's a really good first step. I really appreciated that James was leading that discussion a little earlier on, and standardizing, but also a journey together with organizations in order to build a health system. Health Innovation Manchester, we're based in Manchester, is a good example where we see that different types of organizations are trying to be brought together in order to make the system as a whole more productive rather than the individual parts of it.
Thanks, Bart. And Susan, based on that comment you made about leadership, Susan's put a comment in the chat about middle management is educated to understand the difference between management and leadership. I won't ask the panel to comment specifically on that. Is there any final questions? Is there anything people feel like we haven't picked up from comments in the chat that you'd like to raise before we bring the session to a close? Oh, here we go. Got a last question there from Kate Tattersall. How can we support middle managers to shift from reactive firefighting and meeting overload to focusing on sustainable productivity?
I think, this plays to the question earlier as well, doesn't it, about management cuts?
Yeah.
I think something, James mentioned during the pandemic, the reduction in bureaucracy. There is something about reducing just the sheer amount of guidance and targets so that, less time spent on assurance and firefighting, as it says there, and there's more freedom to do some of the thinking and looking for those bottlenecks that Bart spoke about. I should say as well, though, in terms of management numbers, the NHS again is lower than other places, and there's some good research that shows even a small increase in the number of manager numbers, there is some evidence that shows that does improve performance. So I think certainly there's something about the quantity of management as well. The only other thing, again, to James's discussion is pooling and bringing people together and more peer support that can help, especially within, say, for operational roles, that can help to then share learning across places as well. But yeah, I think it's hard to do if you're cutting management.
I think we face a dichotomy really with this, because I think, again, from digital perspective, I hear time and time again, so organizations wanting to onboard automation or an AI to increase capacity and improve productivity, and yet that stalls because the managers, the team, the leaders cannot spare the capacity to onboard the solution that will improve the capacity. So is it UCL or Imperial did a research paper recently about the delays to onboarding a new AI in medical imaging. So this was an NHS England funded program for 66 organisations to onboard a solution to use in AI with AI for chest X-rays. And of those 66 organisations that signed up to it, only a third of them have fully onboarded it. This is over a space of 2 years, I believe. And it was the big question of what's the prevention, what's stopping the onboarding of, let's face it, a funded program already. And one of the biggest, in fact, I think the single biggest reason for delay of onboarding that was because of capacity amongst clinical teams. They just couldn't give that. So that question from Kate's there is, how do we support, how do we move from firefighting or reactive to proactive? I think if we can answer that question, then that will free up so many other things.
I think it was actually the NHS report or the Productivity Commission report that showed that actually management capacity in the NHS, the share of management functions, is relatively low compared to other public sector organizations and even to private sector organizations. Now, this is a narrative that the general public doesn't quite believe in, right? The general public thinks that, we're spending all this money on managers that are actually not facing patients. So again, there's a narrative here about why that capacity is really important. The other point I wanted to make is the tolerance for failure, which particular in a healthcare system, of course, is very difficult. I mean, we can't afford failure at the front end of our services, and we need to have procedures in place to avoid that from happening. But we tend to have a tendency in the organization then to apply that concept of not willing to fail with your patients to not willing to fail across the entire organization, including the whole back office part of it, where failure is totally fine because you learn from failures and from experiments and you can improve from it. So I think part of the culture is also created because the fact that we're not willing to fail with our patients, and therefore we think we cannot fail anywhere in the organization. That we need to get away from. We need to allow these failures to happen and learn from them across the organization. Difficult to do because it's much easier in many other organizations where you don't have that sort of 100% success rate that you need to strive for at the front end of your organization.
Yeah. We often fool ourselves in the NHS that we are an agile organisation. I think we operate under this misapprehension that we are, and we're not. We couldn't get any more waterfall or linear if we tried. And I absolutely agree with Bart. Sometimes, certainly in digital, you don't know all of the answers. You don't know whether this is going to achieve a benefit or is going to return an in-year saving. But you feel that it's the right thing to do. And so where's the support mechanism to be able to do that and trial it and test it and then look to onboard it? And yes, until we get to that point where we can be truly innovative, we without that incubator to be able to do that, we're constantly going to be asking this question. Constantly. It is very much about reframing the narrative around the view to benefit and cost improvement, and maybe not always letting CFOs have the final say. I'll throw that hand grenade in there. It's
not the final say, yes, but have them at the table. As I said earlier,
indeed.
Cost efficiency is going to be part of the narrative around productivity. We can't get around it. But there's a bigger story to be told than that. Need to be at the table, but not the final word.
Absolutely.
Thank you. On that note, I think our speakers have very eloquently summed that up, that position, and how to take that forward. So if everyone could join me to say thank you to our three speakers, James, Stephen and Bart. Really, really fantastic session. Lots of areas for us to reflect on. So thank you so much for giving us your time this morning. I think feedback in the comments has been so positive. Lots for us to think on. So just in terms of final housekeeping, all of the materials will be shared over the coming days. If you can spare a couple of minutes, please complete the evaluation slide. The QR code is there. This is our final masterclass in our 25-26 series. The new series will be launched on the 13th of May with communicating a new narrative. And other than that, I hope to see you then soon. Okay, thank you. Bye.
Thanks, everyone.
Thank you.